Yeah, Seba, I can hear you. Can you hear me?
Yes, yes, I can hear you.
Yeah, yeah. I think we should proceed. I was setting up my laptop.
Okay, so it's a human DX case. We'll be discussing an 83 years old male who presented with the chief complaints of abdominal pain for 6 months.
Okay, thank you. That's the only complaint, right?
Yes, yes.
Yeah. So we've discussed here a couple of times about abdominal pain as a chief complaint, and it's quite a common complaint in the outpatient or in the inpatient department. So everyone should have his own approach. So mine, for ease of remembering, is I use the anatomical approach. I ask the patient where is the pain coming from, and I think what lies under that particular region, and think of that organ that sits under there. But for me, that's just for remembering. It's not as it's written. Someone can have epigastric pain and they have a cholecystitis, for example. I've seen that. But before moving to that, because that's you're doing that when you're relaxed, you have to first think of someone who is presenting with an acute abdominal pain. This is 6 months, maybe it's not acute, but an acute abdominal pain, because we have to discuss both of them. You have to rule out the things that you shouldn't miss in a patient with abdominal pain, and you use the mnemonic that is called VIPO, V for vascular causes of abdominal pain, and I is any inflammation, anything which ends with an itis. So you have appendicitis, you have cholecystitis, and others that you know. So the VIPO, and so I think P is perforation, while the O is obstruction. And if the patient is a female, you also add pelvic causes, torsion of the ovary or ectopic pregnancy. But I believe that's not the case today. This patient have chronic abdominal pain, 6 months. So we'll go for the anatomical approach, just for remembering. And let's see at the HPI, and we'll get into that. Thank you.
So the abdominal pain was gradual onset, firm, reported to be severe pain. So it is recurrent, progressive. So it initially occurred after eating and walking, and usually it would last for 10 to 15 minutes. And it was relieved by rest and turns. And this usually occurs at, and later on, it started to occur at rest and sometimes even unrelated to meals. So there is a history of significant weight loss, which was reported 2 weeks prior to admission. So it was not associated with chest pain, difficulty in breathing, excessive sweating, or change in bowel habits. So that was the history.
Yeah. So thank you. Um, that's quite a remarkable um, clarification of this abdominal pain. So we heard 6 months, and we said it's a chronic abdominal pain. But if you go like that, it it wouldn't it wouldn't be okay, like totally okay in a patient like this, because this is not a continuous abdominal pain for 6 months. Patients come to you saying, I'm having pain in my abdomen continuously for 6 months. This is an intermittent abdominal pain. And Seba is telling us it comes and go, comes and go. So if the patient presented like uh, the pain started today and they present to me, they say, I had an abdominal pain 2 hours ago, which was there for 10 and 15 minutes. I would consider the pain to be acute. Patient goes away, comes back maybe next month or 6 months later, say that pain is still there, comes and go. So the differential diagnosis wouldn't be the same as saying a continuous abdominal pain. Let's say someone has a tumor somewhere which is stretching the pain receptors, wherever in the abdomen. This is not the case here. So in terms of, I said I will approach it for the anatomical localization. But if you hear in this history, Seba is not telling us that the pain is localized anywhere in the abdomen. That's why I said initially, the localization by anatomy of where the abdominal pain coming, and you think of the organ sitting just below there, is just for remembering. And it's okay to use it. I use it for remembering, but anything can happen. But again, we should discuss another very important thing when it comes to abdominal pain. Like there are things which cut across in the abdomen. They're everywhere. They're everywhere. The liver is in the right upper quadrant. The spleen is in the left upper quadrant. The appendix is somewhere else. The stomach is in the epigastrium. But there are things that cut across in the whole of the abdomen. And I can think of two right now. Maybe I will think of others later. One is blood vessels. So blood vessels run everywhere in the abdomen. And two is the peritoneum. The peritoneum also runs everywhere. So if I'm not being told of where is the abdominal pain coming from, I'll assume this is the whole abdomen is painful. And maybe when we examine the patient, we can have a clue. But for now in history, I'll consider the whole of the abdomen is painful. So it's any of the organ can cause that unless you come and examine and see, okay, the whole abdomen is painful, but more maybe it's on the one side. But if that's not the case, I'll think of those two things: the peritoneum that's painful, plus the blood vessels maybe is the source of the pain. So you do that and start thinking of pain. I don't want to start throwing diagnosis out there, but I'm trying to think. You start thinking of abdominal pain caused by any effect on the peritoneum that comes and go. It's hard to think of that. But when it comes to the vessels, yeah, it makes a lot of sense because vessels can be the only thing that you can have a pathology and then pain comes and goes. The same as when you have the vessels of the heart, the coronary arteries, when they are somehow blocked. So you exert and you feel pain. You don't exert, you don't feel pain. So this is the same thing happening in the abdomen. And so at this moment, I would say looks like the pain can be localized in the vessels of the abdomen, given also the patient is 80s and comes and go, and this pain comes when the abdomen is exerted. When you walk, for example, you exert the heart. When you eat, you also exert your intestines and everything because they start working. So I can localize it there, unless maybe later, and I'll think if that's the case, I'll start thinking. So if I localize it there, what can be the differential diagnosis? Maybe, yeah. Up to you, Seb.
Yes, thank you, Dr. Joseph. I think that is very well explained. So coming to the part of past medical history, so 18 months ago, this patient underwent a cardiac stress test due to the fact that he had a decreased exercise tolerance. So an ECG stress test revealed presence of 1 to 2 millimeters of ST depression, which were prominent in V2 and V3. So Patient was also having some comorbid conditions. So this patient also had CKD stage 4 on conservative kidney management. Is also a patient known to have diabetes type 2. So the latest HbA1c was 6.6, and he's on a well-controlled diabetic diet. There is also a presence of gastroesophageal reflux disease. So the patient has been using antiplatelets, which is aspirin 81 milligram OD. Is also on rosuvastatin 10 milligram daily, furosemide dose of 20 milligram daily, and also losartan 100 milligram daily, and Tums. Tums, these are calcium carbonate supplements that are used for, he usually uses for gastroesophageal reflux disease. So anything, Dr. Joseph, before we go on to physical examinations?
Very important points regarding the past medical history and even the meds as far as is concerned. So, in that cardiac stress test, this patient, he told me he had ST segment depression, which means so the coronaries of this patient are not as clean as we might as we are seeing here. This is what the ECG stress test is telling us. After he was exerted, the coronaries are somehow blocked. The cardiac muscles can't receive the amount that it wants to receive and necessitates the patient to rest because there is changes as we're seeing in the ECG. So this adds into the fact that 83-year-old male with a lot of comorbidities, if this is happening in the coronaries, it can happen in anything. So again, it increases my it takes me towards the direction that I was thinking, that also maybe the abdominal pain is from a disease that is the same mechanism to what is happening in the coronaries, but in the vessels of the intestines and the stomach and everything in the abdomen. Again, things like this also happen. A lot of risk factors that we're seeing here, including CKD, 4, DM, age 83, being male. So all of them, they also are pointing toward the same direction. GERD is also important because GERD also can cause abdominal pain, but pretty typical. Patient will tell you they have, before even abdominal pain, they will tell you they have this regurgitation. Some patient might not tell you they have regurgitation. Maybe they get it when they are sleeping. But if they complain of pain, usually epigastric or even central chest pain, this patient is a GERD. But again, patient is on terms for symptomatic relief, maybe long-term terms, because they've had PPI in the past. So long-term for symptomatic relief. So maybe the abdominal pain is from there, but there is no reason a pain from GERD to be intermittent. This thing is continuous. And as I said, associated with regurgitation of gastric contents. Aspirin is an important risk factor also, which can cause maybe gastric or duodenal ulcers, again, usually localized pain, epigastric or periumbilical somewhere. And we've seen the exam, what we're being told, but again, well, not an intermittent, it can be intermittent, epigastric pain, as you have seen, this very common. Patient have pain and then disappears, comes again, come to the hospital. But to be to come after being exerted, well, less likely. But yes, food can bring the gastric ulcer pain up. I understand that, but exertion less likely. So these are important things to consider that I have seen here. So I think we should continue.
Thank you again, Dr. Joseph. So coming to the physical exam part, so the patient was fully conscious, febrile, not pale, not jaundiced, not cyanosis, was not dehydrated, no any features suggestive of iron deficiency anemia, no abscess ulcers or petechiae, and there was no any lower lymphedema or purple or peripheral lymph nodes. There are no stigmatas for chronic liver or kidney disease. So the vitals were stable, with a blood pressure of slightly elevated, 146/68. Pulse rate was normal, 84 beats per minute, and normal RBG of 5.4. So in per abdomen examination, the major finding was mild diffuse abdominal tenderness. So there was no rebound tenderness. Respiratory system, cardiovascular system, and musculoskeletal all had normal findings.
Okay. Thank you, Seba. So, uh, 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 very helpful physical findings. Patient doesn't look as sick as that, but in the history, we are told this patient has a progressive disease. Symptoms were intermittent initially, but right now, pain even at rest. He's here being examined by the doctor and here the findings. So one thing is confirmed, this is a diffuse abdominal pain coming from everywhere on the abdomen. One organ to cause that in acute setting is possible. I've seen patient, for example, is acute colic, for example, and you touch everywhere, it's painful. But this is not the case. This is the patient who has been having 6 months of pain. Less likely to have pain everywhere, the same pain, and nowhere that the focus is coming from. Okay, but we can say that's just physical exam. But a physical exam, if they can help you, you use them. If they can't help you, you just leave and say you don't know. Maybe you can see in a more a test with a more sensitivity. So also another important thing, someone is examining this patient. They're saying patient has a mild diffuse abdominal pain, abdominal tenderness, and you wonder why, because someone who has been sick for 6 months, a progressive disease, until to the point that the pain is even at rest, and this person who is examining, because this is subjective, I can examine and say I think it's moderate, and someone is saying severe, but why is person concerned about the severity of the abdominal tenderness of this patient? So you start asking yourself questions, maybe is this the pain that we read in books, that patient is complaining 6 months and now pain even at rest, and then the exam is out of proportion of what the patient is complaining about.
Joseph, are you still speaking? Because uh, you are no longer audible. Not sure if you are still speaking.
Oh, sorry, how about that?
Yeah, I can hear you now.
Yeah, I think I lost my connection a little bit. So where was the last point?
So the last point was examination of the abdominal pain out of proportion.
Yeah, so you can think of that. We are being told a mild, maybe because pain seems, patient is complaining a lot, pain even at rest, and then examining is nothing. You think, is this what we read in the books, that it's a pain out of, I've never seen it, I just read it, pain out of proportion to the, what is the patient is saying, which points again to the direction of mesenteric ischemia. But you put that aside so that you can not have a premature closure. You consider everything in totality. So I believe two things. Two things are involved here. Maybe the peritoneum, any disease of the peritoneum to be intermittent, progressive like this. I don't say I know a few. I don't know any. And another, the vessels. I know one. Okay, maybe two. Mesenteric ischemia, both of them mesenteric ischemia, maybe acute or chronic. And yeah, so let's hear more.
So thank you, Dr. Joseph. So a number of investigations were done to these patients. So patient had elevated creatinine levels of about 149. Calcium was elevated around 12.6. The rest of the metabolic panel was normal. Also, serum lipase was within normal range, and the parathyroid hormone was low. So a patient had a H. pylori breast test, which was negative, and the HB was 10.3.
Seba, do you want Joseph to discuss the labs first, or do I project the imaging also?
I think he can discuss the labs, then after that we can switch on to the imaging part.
Okay.
Okay. Thank you very much. So I think in my lab, this creatinine is mildly elevated. I have upper limit of 130. Nothing's abnormal because the total patient is CKD4, so this is the disease that patient is having. An elevated calcium of 12.6. I believe this is total calcium. You must send albumin if you do a total calcium so that you can correct for albumin. We'll assume this is corrected calcium of 12.6. So we're also having hypercalcemia here. And hypercalcemia is pretty important. The patient is abdominal pain because hypercalcemia also presents with abdominal pain. Not only abdominal pain, but this patient will tell you they have abdominal pain, constipation, plus polyuria, I think. Yeah. So we'll put that aside and try to find out why that's so. The rest of metabolic panel within normal limits. And again, before I move from there, calcium also to be considered with we should consider it with much more seriousness because also patient is CKD4, and then they have hypercalcemia. What do you expect in the patient is a CKD? You expect them to have hypo. So if they have hypercalcemia, it seems if this patient had a normal creatinine, maybe the calcium wouldn't be even above this, what we're seeing here. So yes, if you see hypercalcemia, the next step is the PTH. And you ask the question, is this high calcium driven by the parathyroid or not? And the answer here is not. It's not that the person has hyperparathyroidism that is driving the calcium up, but this calcium is independent of the parathyroid. Actually, something else that is releasing the response, PTH is also going down. So you ask yourself, what can this be? And there are a couple of issues there. Very rare stuff like PTHRP, that is parathyroid hormone receptor peptide. I don't know, something which happens, especially with cancers. It's like an I forgot the process in which patient with cancer they release like stuff, and they go and activate these receptors. So I don't think so. We're not told anything of the patient having maybe any cancer, but patient is eating tums. So as Seba told us, this calcium carbonate, I think, and So you're eating a lot of calcium. Maybe you can have a lot of calcium also. I'll put that aside and say maybe it's the terms for now, unless it's so necessary for me to come back to this calcium. Yeah, so I think we can move on. So
Thank you again, Dr. Joseph. So coming to the imaging part, so CT angiogram of the abdomen and pelvis was done, which showed no evidence of mesenteric ischemia, and OGD demonstrated erythema and gastric erosions, together with fundal gland polyps and duodenobulb erythema with 1 to 2 millimeters erosion. So ECG showed a presence of sinus bradycardia and left axis deviation.
okay, can I see again the imaging? Yeah, thank you. So I was moving with the hypothesis of mesenteric ischemia because of the age of the patient, having the same process in the coronaries, and other comorbidities, CKD, DM, stuff like that. But now, a last thing for me was to do CT angio of the abdomen and pelvis, and there is no mesenteric ischemia. I'll point one thing here. So true that most abdominal pain, most causes of abdominal pain will be revealed in the imaging, whether you are doing CT abdominal pelvis or OGD or any other test. So the CT angio, I think, is the test for mesenteric ischemia, but it's negative, so I'll have to consider another cause. And we also told the OGD is demonstrating erythema and gastric erosions. True, maybe patient has erosive gastritis. That's why they're presenting like this. And also we are told they have fundal gland polyps and duodenobulb erythema with erosions. Now, it will be very hard to say why would this first of all start with intermittent pain that is exacerbated by activity and all that. To be very hard. Sinus brady, LAD, nothing significant. So should we rest our money and say the OGD is giving us an answer here? That patient is having erosive gastritis. I think this requires very deep thinking, and I'm not prepared to make it, because erosive gastritis, I've seen a couple of cases that I see them, they have abdominal pain. I send them to gastro does OGD, I see the results, and usually predictable, because the pain is usually epigastric pain, not diffuse, and you do exam, you pinpoint where the pain, where the tenderness is coming from, and even the history does entirely to that. So maybe we go back to the drawing board and ask again, what is the thing that that comes very close? What is the thing that comes very close to mesenteric ischemia, but it's not? So for me, I'll consider what we say now. The abdomen is not a standalone compartment in the in the body. Now I'm stretching my mind here, trying to figure out what is going on. So sometimes you can have pain that is not coming from inside the abdomen, but you feel the pain coming from inside the abdomen. And the answer is there because, you know, the way the abdomen is sitting, it's the abdominal content are pushed up, and some of them are even lying inside the chest. Like you point outside is the chest, but where you're pointing in the lower limbs, that's the organs in the abdomen, but they are lying like in the chest, covered by the diaphragm. So is what we are seeing pain that is patient is telling us coming from the abdomen, but maybe it's the pain coming from the chest. I think I have to move in that direction if I was seeing this patient, because erosive gastritis doesn't make sense. Who will treat this erosive gastritis? But how about the pain that patient is having when they exert? So I think we should reclassify the problem and say maybe the patient with DM odd like this, maybe this is a chest pain. And when we say that, do we have answers? And the answer is yes, because we've had stress ECG telling us there is a problem in the coronaries of this patient, and the patient has also, they have all the risk factors that you know for someone to have coronary artery disease. And again, it's progressive. It's what you call angina, for example. Pain with exertion, pain-free when you rest. Progressive, that the coronary caliber that is being obstructed is still increasing. So you ask me what's the next step here. I say this patient needs to go to the cath lab, not as an emergency, but needs to go to the cath lab, and maybe the cath lab people will tell me now what's happening. If there is something, the cardiologist will work on it and will assess again the patient. Is the pain, does the pain disappear? If it hasn't, maybe something else should be found. So I think, Seba, I'll now move from thinking this is a mesenteric ischemia because it is negative, the angio, and say this was a chest pain that was being felt in the abdomen, and maybe we are dealing with some chronic coronary syndrome. Yeah, unless you teach me if I'm missing anything.
Thank you again, Dr. Joseph.
Yeah, so Joseph, I just wanted, so Seba shared the slides. I also find it very interesting. I haven't tried to look to the end and see what is going on, but I'm just thinking there is this path that you are trying to take, and again, of course, very confusing. I do not know the final diagnosis, but can you try and explore more the idea of the calcium that you started with, because you talked about the calcium with calcium explaining the abdominal pain. You mentioned some other symptoms that were not present in the patient, like constipation. And again, I see the OGD is showing some gastric erosions, which I know hypercalcemia can be associated with peptic ulcer disease. Can you try and explore more the idea of the hypercalcemia? Maybe we can learn something from you.
Yeah, so whenever you see hypercalcemia, they say the first question is to ask, is it being driven by parathyroid hormone, like in a patient with primary hyperparathyroidism or not? And it's easy to do that because you just send the hyperparathyroid hormone, and it was sent here. It was not elevated. Actually, it was low. So you say this is not hypercalcemia that is being driven by hyperparathyroidism. So what else can cause that? And usually one is parathyroid hormone, like it's called PTHRP. This is a peptide that is produced. It's like let's say you have a lung cancer, for example, and then the cancer releases this peptide. This peptide activates the parathyroid hormone as the parathyroid hormone does, and again, it's like a pseudo signal that causes calcium to go up. That's one. Number two is you have other diseases, for example. You have other diseases like any bone disease, for example, bones being distracted and you release calcium in the system. Number three, you can have, if you talk to calcium, you should talk about parathyroid, which you have done. You also should talk about vitamin D. And vitamin D, if it's elevated, also causes hypercalcemia. So you can go into that direction and find out what are the things that can cause elevated levels of vitamin D, including intake of vitamin D itself or endogenous diseases. Endogenous diseases like any disease that will cause granuloma, TB maybe, and the other one was very common, I forgot it. Also can go into that direction. It's like leaving my mind here, but I think I'll remember it later.
Sarcoid?
Yes, I mean sarcoid. Yeah. So any sarcoid also presents with granulomas. As granulomas, you have elevated vitamin D, and you know that. That's a very hard direction to take. You say this is a cancer. I don't see why it causes. Maybe there is reason why it causes intermittent symptoms and symptoms that comes and disappear with exertion. Yeah, Tams I've read about case report patients eating a lot of Tams and they have hypercalcemia.
Yeah, so I'm thinking because again, I think I've read, but that was very long ago, a case of milk alkali syndrome. But then I do not remember the clinical presentation of milk alkali syndrome. Could this be the case here? And again, of course, when Seba reveals the final diagnosis, we'll learn from him. But if you have any idea about milk alkali syndrome, could it be the case here?
Yeah, so yes, so what we are talking about here, excessive intake of calcium from TAMs and whatever. You know, TAMs are available in Tanzania now. Maybe you start seeing it. They have been like marketed in the radios and TVs. So the milk alkali syndrome is what we are saying, excessive intake of calcium. And there is a nice history if you read there. It's called milk alkali syndrome because there was, I think, the doctor was called CP. This CP he was a surgeon. He used to treat gastric ulcers and functional gastritis with milk and a lot of calcium. So the milk alkali syndrome came from what this doctor was doing to the patient. He was giving them a lot of calcium to eat and then giving them milk. So they called it milk to alkalinize the acid in the abdomen. And yeah, that was the case. But I don't think this is the case here because that will only explain hyperthyroidism. It won't explain other symptoms the patient is presenting with. And even if that's the case, this patient at the end needs to be treated. The positive ECG from stress test need to be treated because the next step is to go to the cath lab, not on an emergency basis, but as a planned procedure.
Okay, very interesting. Again, just like you, I think I'm struggling to see what the final diagnosis is. So so Seba, do you allow me now to project what the final diagnosis is, so you can teach us?
Yes, I think we can proceed. So what we came up with from this HumanDx case, so it is significant atherosclerosis presenting with chronic mesenteric ischemia, then also chronic coronary syndrome. So yes, the sensitivity of diagnosis when it comes for when you use CT angiography in detection of mesenteric ischemia is as high as 90%, but presence of an absence of normal coronary normal CT angiogram of the abdomen does not completely rule out presence of mesenteric ischemia, especially when you have severe pain that is out of proportion to exam. For example, in this in our patient. So our patient underwent left heart catheterization. So she was also found to have a severe triple vessel disease. So after severe triple vessel disease, interventions were done. So 3 stents were placed, which were drug-eluted stents in all the 3 culprit vessels. And after implantation of the coronary percutaneous therapy, the pain significantly improved. And after cessation of the TAMs, which were the calcium carbonate, which were taken for the reason of controlling GERD, the hypercalcemia also improved. So maybe some few teaching points regarding the chronic mesenteric ischemia. So this is usually a manifestation of peripheral vascular disease that is caused by an insufficient blood supply to meet the metabolic demand of the visceral organs. So the term that has been coined to explain mesenteric ischemia is what we usually call intestinal angina. So when you take food, it's like you are exerting the gastrointestinal system. So more metabolic demand metabolic demand is heightened when you take food. So the extent of pain usually it's unmasked when patient takes food. So it's like physical exercise when it comes into coronary syndrome. For the GI system or mesenteric ischemia is when you take food. It's like you press significant exercise into the gastrointestinal system. So the chronic mesenteric ischemia is usually due to atherosclerotic narrowing of the mesenteric vessels. And both vessels, major vessels such as the celiac artery, superior mesenteric and inferior mesenteric, all can be affected. But the one which is more affected is usually the superior mesenteric artery. So the risk is usually compounded by a number of risk factors. There are some which are modifiable, and some of the risk factors are non-modifiable. But high on the list is usually the same risk factors which are in the spectrum of causation of atherosclerosis. Smoking high on the list, hyperlipidemia, and also presence of diabetes and hypertension. So the classic presentation of mesenteric ischemia, as Dr. Joseph already told us, is usually postprandial abdominal pain, which is termed as intestinal angina, occurring 15 to 30 minutes after eating, and it may last up to 4 hours. Although there are other non-specific symptoms such as nausea, vomiting, and early satiety, sometimes even diarrhea or constipation may happen, but the classic presentation is postprandial abdominal pain. So in majority of the patients, this presence of postprandial abdominal pain usually causes them to develop the fear of eating, which causes significant weight loss. So atherosclerosis is the leading cause of chronic mesenteric ischemia, and that is caused by narrowing of the mesenteric vessels. So this one is, I've already explained about it. So how common is mesenteric ischemia? So it's a relative common condition. and it is reported up to 10% in populations who are older than 35 years, and females are more affected than males. So in physical examination, usually findings are minimal, and the abdomen typically is usually soft without any peritoneal signs, though the most common sign that could be found is presence of diffuse abdominal tenderness. And it's common for mesenteric ischemia to have the pain which is out of proportion to physical exam. So in history, patients will present with significant pain that may be ranked from 9, sometimes even up to 10. While when you come into the part of physical examination, you'll find some almost mild diffuse tenderness. So sometimes there is discrepancy between history and physical examination. So presence of an abdominal bruit is usually common. So up to 50% of patients who are having chronic mesenteric ischemia due to significant atherosclerosis may present with an abdominal bruit, although it's a sign that has been highlighted to lack sensitivity and specificity. So mesenteric ischemia usually does not go isolatedly. So it's usually associated with other atherosclerosis in other parts of the body. For example, in the peripheral blood vessels, so it's highly associated with the presence of peripheral vascular disease. So patients will be presenting with other clinical presentations like intermittent claudication, and also for the part of chronic coronary syndrome, these are the patients that will have chronic exertional dyspnea. So of particular importance when it comes into chronic mesenteric ischemia, this is one of the diseases that are underdiagnosed in most of the scenarios. So majority of the patients who present with chronic mesenteric ischemia, they're usually treated for sometimes even months up to years, treated for peptic ulcer disease, sometimes cholecystitis, and even sometimes presence of gastric malignancy due to the presence of anorexia and also weight loss. So the index of suspicion for malignancy usually may be high, and sometimes people tend to miss the diagnosis of chronic mesenteric ischemia. So definitive diagnosis is usual vascular imaging to demonstrate presence of stenosis. But as I said during my opening statement, in this teaching points, presence of a normal CT angiography does not completely rule out presence of mesenteric ischemia. So CT angiography is the most preferred method because of it being non-invasive. But in areas where you have no access to CT angiography, then the use of mesenteric ultrasound is considered a reasonable screening tool, though sensitivity is quite lower in comparison to CT angiography. So the primary objective when it comes into management of chronic mesenteric ischemia is to alleviate the abdominal symptoms, facilitate weight gain, and also progression to an acute mesenteric ischemia, which is considered more lethal. So management of chronic mesenteric ischemia is based on symptom severity and the condition of the patient. So we have two major spectrum. We have patients who are asymptomatic and symptomatic patients. So asymptomatic patients are usually managed conservatively with lifestyle modifications, including halting of the prominent risk factors such as smoking, if at all the patient was a smoker. And also antiplatelets play a crucial role in management of chronic mesenteric ischemia. So in selected cases, so there is a role of short-term medical management, such as performing bowel rest via introducing parenteral nutrition. But this should not be used for a longer period of time and should only be used as a bridge when you are planning to perform a revascularization therapy in these patients. So patients who are symptomatic, for example, in our patients, then surgical or endovascular revascularization is indicated. So endovascular is the most preferred rather than open abdominal surgery due to its minimally invasive nature and also fewer perioperative complications, keeping in mind majority of these patients are elderly patients who are more likely to succumb into multiple complications if they tend to undergo open abdominal surgeries in comparison to endovascular surgeries. So indications for surgery include presence of signs of peritonitis, which is usually common when these patients develop acute mesenteric ischemia, and also massive lower gastrointestinal hemorrhage. So one of the complications of mesenteric ischemia is usually development of massive gastrointestinal hemorrhage. So this is also a cause that people should also be thinking of it when you have patients, elderly patients, 60 years and above, comorbid conditions such as presence of hypertension, chronic coronary syndrome, and presence of intermittent claudication suggestive of peripheral arterial disease. So if at all this patient is presenting with massive low GI bleeding, mesenteric ischemia is one of the most important differentials that that somebody should think of. And also chronic malabsorption, usually leading into protein losing colopathy, is also an indication for surgery. And also presence of colonoscopic evidence of segmental colitis with frank ulceration. And also development of ischemic stricture together with associated abdominal symptoms. There are also indications for surgery. So overall prognosis is poor in patients who are having mesenteric ischemia. So the 5-year mortality remains up to 40% in patients who are having untreated. 40% is for those who are symptomatic, but for the symptomatic cases, 5-year mortality is as high as 100%. So you can imagine the severity of this particular disease. And the other most common cause of death in patients who are having coronary mesenteric ischemia is other conditions that are associated with significant atherosclerosis, in which myocardial infarction is usually high on the list. Yes, Dr. Joseph, and this was my teaching points.
Yeah, thank you very much. I think that's a very nice job. We all should emulate you. You didn't just those teaching points in the HumanDx. It's just short, but went further and read about this topic and put some other information here that I think very nice. We are learning them. Um, that is very very good. And for everyone else, everyone here is learning, but two people are learning more than everyone else. The one who's presenting the case because they have read it, and the person who is discussing. So, for example, I learned here CT angio, the sensitivity 90%, you have a chance of missing it. If I had that, poop, could have arrived at the diagnosis easily. And so you should all present or discuss cases. That's the wake-up call. Thank you very much, Seba.
Thank you. Thank you to Dr. Joseph.
Yeah, thank you very much, Seba, for presenting the case, and Joseph for discussing. This was very interesting, and I was sitting on the edge of my chair because I wasn't. I kept asking myself, what is the final diagnosis? Because as it started, I had the same thoughts as Joseph that, okay, this could be mesenteric ischemia. But then when you presented that CT angio was normal, my hopes went very down. So I started thinking about other things, including the calcium, which again, of course, can explain abdominal pain, but not the intermittent nature of this abdominal pain. So it was a very tough case and good for learning. And I think the learning that we've done today, after Seba presented the teaching points after the case, I think the retention will be higher than if we just went to books and read about mesenteric ischemia. So that was a job very well done. The chat was very quiet today. Uh, is there anyone who has any comments, any questions, anything to share before we close? I do not see any hands. So next week, so I talked to Michael today. He has like two cases, but one is very ready, and therefore next week he will have prepared the slides and ready to present. So I hope because it's been a while since Joseph discussed a case here, I think Joseph will be happy to discuss that case also. So next week we hope to have a case from Michael discussed by Joseph, and we encourage we encourage everyone else because we know that you are seeing many interesting patients who we can learn something from, and therefore even if the case is incomplete, you can bring here so we discuss and we can come with the final diagnosis, or at least add some inputs that can help improve the patient's management. So bring cases and volunteer to also discuss cases so we can learn from your thought process. So if there is nothing else, I thank everyone for sticking around for the hour, and have a good night. See you next weekend.
Good night.